Hi everyone. I'm a lecturer in behavioural rheumatology at the University of Birmingham, and it's a great pleasure to present some findings from our case study for PREFER. Next slide, please. So as Kareem mentioned earlier, there's a growing interest in the idea of preventing RA by treating someone before they have developed full-blown symptoms of rheumatoid arthritis. So, sorry, can we go back to the previous slide? Thank you. So it's really important to understand the perspectives of everyone who might be affected by this approach. And this is something that we've been interested in for a number of years at the University of Birmingham as partners in several previous European consortia. So we've done a number of exploratory studies using focus groups and interview techniques, and also a survey to try and get a feel for all of these different groups, including people who are at risk or have an elevated risk of developing RA, such as first-degree relatives of RA patients and people who have symptoms or autoantibodies that are associated with RA development. Next slide, please. So one of the key themes that recurred across these previous studies was that there was a huge unmet need for informational resources for people about who is at risk of getting rheumatoid arthritis and what they might be able to do about it. And so in the Euroteam project, which I think you'll hear about again later on, we were lucky that we were able to work with an international team of patient research partners and clinicians and researchers to develop just that, some informational resources for people who might be wondering what their risk of getting rheumatoid arthritis is. And one of these, which was aimed at relatives of RA patients, has now been adopted by the National Rheumatoid Arthritis Society in the UK and is publicly available on their website. Next slide, please. So it made perfect sense for us as partners in PREFER to study the preferences for preventive treatments for rheumatoid arthritis, because we already had a lot of exploratory studies in this area, and it would be really nice to have a chance to quantify and really measure people's preferences for benefits and risks of aspects for preventive treatments. So we wanted to know what characteristics of treatments were important to people when they were making decisions about whether or not they would take a preventive treatment, and what level of what risks of side effects they would accept in exchange for a given treatment benefit. And we were also, in the same way as Karen has just explained, we were interested in what kind of characteristics predict people's or different groups of people who have different preferences. And we also wanted to be able to assess what the likely uptake would be for preventive treatments for RA. So we designed a survey study. I'm not going to go into detail about how we did that here because it would just take too long. But it was informed by a previous qualitative study and also by a literature review, and also addressed lots of other methodological objectives, which I'm also not going to speak to. But if you are interested in that detail, then the study protocol is now published, and you can visit that after today for more information. Next slide, please. So our survey was completed by almost 1,000 people in each of 3 different European countries. So we had very large samples of the general population via online survey panels. And we also recruited first-degree relatives of RA patients via rheumatology clinics. So we asked patients or we invited them to ask their relatives if they would like to take part in our survey. And so we also recruited just over 350 first-degree relatives in the UK and also in Germany. Next slide, please. And all of the participants in our survey were asked to imagine that they were experiencing some joint pain and stiffness, and that they'd had a blood test and it showed that they had a 60% chance of developing RA in the next 2 years. And we asked them to imagine that their doctor has suggested that they might want to consider taking one of the following treatments for a year, and then asking them to choose between 2 different treatments, treatment A, treatment B, or to opt out, to have no treatment. Next slide, please. And this is an example of the kind of question that the participants in our survey answered. Each person actually answered 15 of this kind of question. And in the same way as we've just seen for Karen's study, each treatment option was described in terms of its level of several different treatment characteristics or attributes, including its effectiveness to reduce risk of RA, how it's taken, whether it was a pill or an injection or an infusion. Sorry, the slides keep jumping ahead of me. And also the risks of various side effects, including mild side effects, such as nausea, the chance of developing a serious infection that they could end up in hospital with, and also the risk of a serious side effect, such as developing lymphoma. Next slide, please. And so I'm going to go straight to some results. So this is results for the general population sample, and it's stratified by the 3 different countries that we looked at. So all in all, this is about just under 3,000 participants. And in all 3 countries, treatment was preferred over no treatment, and treatment effectiveness was the key driver of people's choices. But there were some differences across countries. In the sample in Romania were more sensitive to the chance of serious side effects and the chance of serious infection when they were making their choices. And they were also more likely to always choose no treatment. So almost 10% of the sample in Romania always chose no treatment. Next slide, please. And so we were able to assess the level of risk of each of the treatment risks that people would accept for a 40% reduction in their risk of getting RA. And in all 3 countries, participants accepted very little risk of very serious side effects and higher risks of serious infection, and even higher risks of very mild side effects. And there were some differences across the 3 countries. So in Germany, participants were much more accepting of a risk of serious infection than they were in Romania, for example. And there was a tendency for the sample in Romania to be less accepting of risk than in the other 2 countries. Next slide, please. So as I mentioned earlier, we also recruited a sample of first-degree relatives and wanted to compare the results for them with the results for the general public. And this is a summary of that. And you can see that the pattern of preferences was very similar in the sample of first-degree relatives as it was in the general population. The only really notable difference here is that first-degree relatives were much less bothered about how the treatment was taken, so whether it was a tablet or a drip or injection. And first-degree relatives accepted higher levels of risk numerically, but this wasn't statistically significant. So very similar results overall. Next slide, please. And like Karen, we were interested in the fact that different groups of people have different preferences. And in our analysis, we were able to identify 5 such groups with different patterns of preferences. And the participant characteristics that predicted which group a participant was most likely to belong to were measures of health literacy, reported numeracy, perceived risk of developing RA, and also people's beliefs about RA, so how seriously it would impact on them if they were to develop RA, and how effective their treatment would be if they were to develop RA. Also their beliefs about taking medicines in general, and also which country they were in. Next slide, please. So we also included an additional choice task in our survey, as well as the ones that I've seen you, where we asked people to choose between 4 different treatments to opt out. And these treatments are based on the drugs that are mostly currently being used to treat RA, but are being investigated for their effectiveness to reduce risk in people who are at risk. So they haven't known side effects and characteristics, but we asked the researchers who are leading prevention trials for RA to help us estimate their effectiveness to reduce risk of RA. So these treatments are intended to reflect the kinds of treatments that are currently being investigated to see if they can reduce people's risk. And we asked people to choose between them, and you can see that the least popular choice was no treatment. Most people chose one of the 4 preventive treatment options. Next slide, please. So to summarize some key conclusions, effective treatments to prevent RA were acceptable to most people who were asked to assume that they had a high chance of developing RA in the next 2 years. And we were able to identify different groups of people who were likely to have different preferences, and we were able to explain some of that variability with participant characteristics such as health literacy and numeracy and so on. Now, we asked people to imagine that they are at risk of developing RA, but what we really want to do next is to do a similar kind of study with people who really are at a high risk of developing RA. So, for example, people who have symptoms such as arthralgia or joint pain that indicate they have a high risk of developing rheumatoid arthritis in the future. So that's some further research that needs to be done in this area.